One of the most serious complications associated with congestive heart failure and other cardiovascular problems are cardiac arrhythmias. Cardiac arrhythmias may also happen due to ischemic heart damage, heart failure, hypervolemia, hypotension, electrolyte disturbances associated with potassium, magnesium, and calcium, and also those associated with drug toxicities such as digoxin, antiarrhythmics, caffeine, and alcohol. Always remember that antiarrhythmics in higher doses can actually turn pro-arrhythmogenic. Before we look at the drugs used to treat cardiac arrhythmias, it's important to cover the physiology of the action potentials, first in the fast fibers of the bundle of His or the Purkinje fibers, and also those in the slow fibers associated with the SA and the AV node. The first thing to note is the cardiac action potential in the fast fibers. Phase 0, or the depolarization phase, is totally dependent on the sodium channels. The faster the sodium moves down its gradient, and the quicker the sodium channels open, the faster the rate of rise of the depolarization phase. This is dependent on sodium channels, and as a result, class 1 antiarrhythmic drugs will slow or block phase 0 in the fast response fibers. Phase 1 is the overshoot phase, where the sodium channels are inactivated and in some Purkinje cells you'll have a very transient outward potassium current and inward chloride currents. Phase 2 basically is where you have a slow influx of calcium, which is balanced by a late appearing outward potassium current, often referred to as the delayed rectifier current. Phase 3 is the repolarization phase, where you basically have sodium being returned to its channels, and basically this is also due to the delayed rectifier potassium current, where potassium is being pushed out of the cell and the cell returns to its negative resting potential. Phase 4, or the final phase, is the return of the membrane to the resting potential, where sodium is eventually returned to its sodium-potassium ATPase channel. Now, the calcium currents basically allow for the rate of rise of phase 0. There is no involvement of sodium here, and the rate of rise of the depolarization phase is basically due to the influx of calcium. The depolarization depends on the activation of the L-type and the T-type calcium channels. Since this is dependent on calcium, class 4 antiarrhythmic drugs will slow or block phase 0. During the process of repolarization, the calcium currents become opposed, and you now have the delayed rectifier potassium current. The major distinctive feature of the slow fibers is that in phase 4 they have spontaneous depolarization, often referred to as the pacemaker potential. This is usually due to an inward sodium current and calcium current and outward potassium current. Class 2 and Class 4 antiarrhythmic drugs will slow phase 4 in the pacemaker fibers, flatten out the spontaneous depolarization. It is important also for us to understand the role of the action potential duration, the effective refractory period, and the relative refractory period. The ERP, or the effective refractory period, is a time when no stimulus of any magnitude will elicit a response, and this will last into stage 3 of the action potential, because the sodium channels are inactivated and not in the ready state. Those that block the potassium channels will block the effective refractory period. Essentially, the whole idea behind the antiarrhythmic drugs is to delay the effective refractory period and move this curve to the right, slow down depolarization, slow down repolarization, so that the onset of the next action potential is essentially slowed down. The relative refractory period basically is a very small window during a time when a strong stimulus can elicit a response, but this will basically cause an ectopic beat or an arrhythmia. So basically what happens, you may also have a re-entry problem, where if you look normally the nerve impulse goes down the ventricular wall. However, if there is a unidirectional block, the impulse will travel in a retrograde fashion, and re-enter the conduction pathway and ultimately cause an or irregular heartbeat. Similarly, the Wolff-Parkinson syndrome happens this way, and this is basically due to the pre-excitation of the ventricles or an extra accessory pathway. So the types of arrhythmias are classed as the atrial arrhythmias, atrial flutters, atrial fibrillation, and then you have the SVTs or supraventricular tachycardia, which is due to an AV nodal re-entry or an acute supraventricular tachycardia, or ventricular tachycardia is classed as an acute ventricular tachycardia and ventricular fibrillation. The classes of the antiarrhythmic drugs are indicated in bolding. Those are the ones that are the preferred drugs and are the commonly used drugs for each of the types of arrhythmias. And typically the sodium channel blockers are very commonly used because they both effectively block the arrhythmias. So your class 1 drugs are classed as the sodium channel blockers. Class 2 are your autonomic nervous system drugs or the beta blockers. Class 3 are the potassium channel blockers, and Class 4 are the calcium channel blockers. Those miscellaneous drugs that do not fall under any of the above classes I will mention a little later. The Class 1A antiarrhythmics is quinidine and procainamide. Quinidine and procainamide are the two most commonly used ones. They will block both the open and activated sodium channels and reduce the influx of sodium, and also to a certain extent block the potassium channels. This will delay or slow down the depolarization phase and ultimately cause an inaction potential duration and effective refractory period. They're used for all types of atrial and ventricular arrhythmias, and procainamide is also used to reverse arrhythmias during acute myocardial infarction. Typically, quinidine is your first line. So you're blocking the sodium channels, you're slowing down the depolarization phase and delaying the action potential duration and the effective refractory period. Procainamide is actually converted by N-acetyl procainamide to N-acetyl transferase. And the common side effect of procainamide in slow acetylators is the SLE type syndrome, which is reversible. Hypotension may also happen, and it also has CNS side effects such as depression, hallucination, and psychosis, and it may precipitate new arrhythmias. Quinidine is the most commonly used one and is associated with quinidine syncope, which is dizziness and fainting, because of ventricular arrhythmias associated with the prolonged QT interval. Since it contains quinine, the other important side effect is synchronism, which is deafness, tinnitus, blurred vision, flushing, and tremor. The way overdoses are treated is basically hyperkalemia can exacerbate the cardiac effects. It can be reversed by using IV sodium lactate. And sympathomimetics can be used to reverse the drug-induced